This topic is dehydration. Dehydration, as we commonly know, is due to fluid loss, and we do lose electrolytes during dehydration as well. So let's talk about the causes of dehydration. We can have that fluid loss through the GI tract when we have vomiting or diarrhea. Decreased oral intake can occur, especially when we're sick and not feeling well, if clients are nauseous or having decreased appetite. Insensible losses are another way that we can lose water, fluid, and electrolytes. Insensible losses are most common through the skin, through sweating, or through the respiratory tract if there's hyperventilation. Burns and trauma can also lead to dehydration. Specifically with burns, there's a disruption in the skin integrity, so we have a greater loss of fluid. And with trauma, we can also have a greater loss of fluid, such as extreme blood loss, which can lead to dehydration. Dehydration can rapidly progress into hypovolemic shock. Again, we have a decreased volume within the body. This can be concerning, and so we need to be aware of the symptoms and be able to treat early. I do want to highlight that children are at a higher risk of dehydration as they have a higher percentage of body water to their surface area. They also don't respond promptly to some of these fluid alterations within the body, so they are at increased risk for dehydration. So as we mentioned in the previous slide, dehydration occurs due to fluid loss as well as disruption in electrolytes. But we do need to remember that serum sodium, or the sodium that's in the bloodstream, is going to be the telltale sign of the type of dehydration we have. And just remember, water will always follow sodium. Isotonic dehydration occurs when we're losing an equal amount of water and electrolytes, such as sodium. So when we have both being lost at the same level and same proportion, this can be a great risk for dehydration that can lead to severe shock. Typically in dehydration, the body will try to compensate and move water appropriately. But in this case, since we're losing electrolytes and water at the same pace and amount, the body's not able to do that. This is actually the number one type of dehydration that children will experience. Hypotonic dehydration occurs when, remember, we're still losing fluid, but we're losing far more electrolytes than we are fluid or water loss at this point. So think of a marathon runner. When they're running, they're losing water, fluid, as well as sodium through their sweat. If the marathon runner goes and drinks a bunch of water to replenish themselves rather than a sports drink with electrolytes, there's going to be this continued large imbalance of higher water and far larger deficit of electrolytes. Hypertonic dehydration occurs when we have an increase in fluid loss rather than electrolyte loss. So an example of this would be a client who's using diuretics or maybe misusing diuretics. They have an increased fluid loss rather than electrolyte loss. The client will be hypernatremic or have a high serum sodium. Our clinical features will actually appear based on the severity or degree of dehydration. And remember, we are having water or fluid loss with each type of dehydration along with electrolytes. So water loss means weight loss. So in a mild type of dehydration, this is around 3 to 5% of weight loss due to that fluid loss. The client may not be extremely symptomatic. They will have increased thirst, decreased oral intake, or increased losses such as vomiting and diarrhea. Again, the client may not be very symptomatic. Moderate dehydration, these clients experience about 6 to 9% of weight loss due to that volume loss. So here we will see decreased skin turgor. Skin turgor is the skin's elasticity. When we're well hydrated, if we pinch the skin, it should go right back to how it was. It should bounce right back. With decreased skin turgor due to dehydration, that skin may take longer to go back to its original shape. We'll see dry mucous membranes. So if you look in the mouth, you may notice that it's more pale and dry, and we can even have cracked lips. Clients may have sunken eyes due to their dehydration, and most specifically in babies or infants, we can see a sunken fontanelle. The body is also going to compensate and try to work with this decreased amount of volume, so the heart is going to pump faster, so we'll see tachycardia. This is to ensure that the body and extremities are still well perfused. Due to that volume loss, the client will also experience decreased urine output. Severe dehydration is defined as clients who lose over 10% of their body weight due to that volume loss. This is an emergency, as these clients may be heading into a hypovolemic shock. These clients will be listless, lethargic, maybe even unresponsive. We need to remember that serum sodium is going to tell us what type of dehydration we're experiencing. So if this client has a low sodium, that directly affects our brain, and this can lead to that unresponsiveness or lethargy. The clients may also have a weak pulse and hypotension due to this severe volume loss. The body is heading into a hypovolemic shock, so it's still trying to compensate, so we'll see tachycardia and tachypnea, or a higher respiratory rate. Decreased capillary refill, which is over 2 seconds, is concerning, which means there's decreased perfusion to the extremities. We'll see skin tinting. Again, that elasticity in the skin is gone, and it will stay tinted up like a camp tent. Oliguria, very minimal urine output, or anuria, no urine output, can be present as well. Remember, these are signs of severe dehydration and shock, so we need to intervene immediately. So let's talk about how to intervene for these clients with dehydration and how to assess appropriately. These assessment tools and tips are important for any client to assess for dehydration. Checking capillary refill, making sure that it's less than 2 seconds. Remember, capillary refill is when we press on our fingernail, it'll turn white, and that's because we've occluded the blood flow. And when we lift up, the nail should go right back to its pinkish tinge as the blood flow has returned. If this is more than 2 seconds, that's concerning. We want to monitor skin turgor, that elasticity in the skin, as well as mucous membranes to make sure that they're well hydrated and moist. Checking the fontanelles in infants to make sure that they're not sunken, as well as daily weights. Again, we want to check the amount of weight loss, which will be equivalent to the volume loss. Rehydration therapy is important. For mild to moderate dehydration, the clients can replenish themselves with oral rehydration. We want to make sure we're not just replacing with water. We want to make sure that we're including these electrolytes that the client has lost as well. So sometimes a sports drink can be helpful. In severe dehydration, we do need to use an IV solution, such as an isotonic crystalloid. An example of an isotonic crystalloid is 0.9% sodium chloride or a lactated ringer. This will help replenish the volume as well as the electrolytes lost. Advancing diet as tolerated is important as well. Some clients have been experiencing nausea, vomiting, and diarrhea, so slowly advancing their diet will be helpful. Or we want to make sure these clients are safe to eat if they've been unresponsive, listless, or lethargic. Strict intake and output and monitoring serum electrolytes is also important. Again, we want to make sure we're replacing any electrolytes that have been lost. And monitoring for an increase in that urine output if the patient was experiencing oliguria or anuria.